Hello, everyone, and welcome to this event today. We'll go ahead and get started. It gives me great pleasure to be here today to kick off this event, which is the first in a series of events that we'll have to celebrate 10 years of the Johns Hopkins International Injury Research Unit. While we've been doing work on injury prevention around the world for many more years, about 10 years ago or so, Adnan had this vision of creating this injury research unit to bring some of us together. I say some of us, but at that time when he had this vision and was forming this unit, I was one of the research assistants as a doctoral student in the room where we were 3 people. But now with all this work going on, we've grown, and we're here celebrating 10 years of work that we've done around the world. This topic is really interesting. It cuts across many different aspects of public health, including injury prevention. And so it's really relevant for us to be kicking off our 10th anniversary events using with this event and with this topic in mind. So I won't spend too much more time talking, but I'll invite Adnan, who's our director of the unit, to come and introduce the speakers, and he'll serve as the moderator for the rest of the session.
Thank you very much, Abdul. So welcome to all of you to this event, which is on alcohol, as well as to the beginning of our 10-year series of events. We hope over the next 10 months to actually have 10 different events. We'll have them, some of them will be here in Baltimore, others will be internationally, some domestically. We hope to have at least one event in New York City, and then in Bangkok, in Kampala, in Uganda, and so on. So it'll be a nice international gathering. What we are hoping to do is to live stream every event, including this one. So one of the key things I want to let everyone know is that whether you're a speaker or you're going to ask a question at the end, please use a microphone, because we have colleagues who are signing on not only from other parts of this city, but also other parts of this country, and some of our international colleagues are signing on to listen to our wonderful set of speakers today. So please, just as a word of caution to all of us, let's not stray away from our mics. We are beginning with a session on alcohol because repeatedly, estimations of the global burden of disease and risk factors has demonstrated that alcohol is in fact the leading public health risk factor, whether you count it in deaths, or you count it in morbidity, or you count it in disability-adjusted life years, whatever is your favorite metric. Because alcohol affects injuries, it affects violence, it affects heart disease, it affects mental health. There are just such far-reaching effects of alcohol. And so it seems highly appropriate that as a School of Public Health, where we are based, we start off with a macro perspective and handle and discuss something around this particular risk factor. What I'm particularly delighted about is that we have a panel that really comprises some of the cutting-edge knowledge around alcohol. I'm excited that co-hosting this event is our Johns Hopkins Center on Alcohol Marketing and Youth. And we'll be hearing in just a minute from Professor David Jernigan, who is the director of that center and a leading authority on looking at alcohol marketing and fundamentally around conflicts of interest, and thinking about how risk factors and people who work in public health to promote the health of populations, what is that relationship? Some of you might know that a few days ago, the Global Fund signed an agreement with Heineken, which is the beer manufacturer, so that Heineken will be supporting the Global Fund. And there was a lovely photograph of the chiefs of Heineken and Global Fund shaking hands. And that was awful to the rest of us, because what this means is that Heineken has the capacity to influence the work of a global agency. One of our alumni from the School of Public Health here, an MPH program, Robert Martin, is working on his degrees at the London School of Hygiene and Tropical Medicine, his doctoral degree, and he, day before yesterday, published in the Lancet, Stop the Toasts, the Global Fund's disturbing new partnerships, because they were toasting this partnership, and he is raising, so our alumni are out there raising this consciousness, and I hope that we will hear a lot more from David. I also want to particularly thank the National Academies of Sciences, Engineering, and Medicine, many of whose staff are present here today, for this collaboration. They are also partnering on this event. And we will have Amy Geller, who's a senior program officer from there, to discuss their latest report, released just a few weeks ago, around alcohol, with a particular emphasis on its impact on drink driving and other types of public health impact. And I'm always delighted with one of our students can step up to the plate, and very excited that Dr. Nukhba Zia, who's pursuing a Doctor of Public Health here in our department, will be talking about data systems. We can't have a session, of course, at the school without data. So Nukhba will talk to us a little bit about those data systems. So that's the agenda for this seminar. What I would like to request is that I think what we'll do is we'll do the 3 presentations and then open it up for questions, because in fact these speakers have coordinated a little bit. So there will be a little bit of segue and overlap for us to have a full picture of the impact of alcohol in public health. I also want to thank the school, which is tremendously helpful in all our events, and particularly the Department of International Health and the Health Systems Program, which of course supports us in many, many different ways. And I'm really excited that all of you have come here today. And for those of you who are listening to us on the live stream, welcome as well. I'm sorry that we may not be able to get questions from those of you watching us on the internet, but hopefully our technology will evolve over time that we'll be able to do that as well. So let me first introduce David Jernigan. As I've said, he is the director of the Johns Hopkins Center on Alcohol Marketing in Youth. But in addition, David was part of the committee that the National Academy of Sciences put together, the report that was released a few weeks ago, and Amy will provide us a summary later on. What I'm hoping that David will do is really set the stage of where does alcohol fit within the larger public health remit, and that will allow us to contextualize the rest of the discussion. So thank you very much, David, for coming, and over to you.
Thanks, Adnan, and thank you all for coming. My job is to give all the bad news. Amy's job is then to follow up with the good news. I want to reserve most of the time for the good news. So my comments, surprisingly for me, are not terribly long. I first just want to notice that the real SDGs are the Sustainable Development Goals. I'll talk about other SDGs in a little while. But the real SDGs are the Sustainable Development Goals, and Target 3.5 is explicit this time around regarding prevention and treatment of substance use, including not only narcotic drug abuse, but also harmful use of alcohol. So there is a global target. There is certainly, I've been working on these issues for 30 years. Over that time, the profile of alcohol in global health has expanded. We've gotten better at measuring and documenting it. As Adnan says, alcohol touches so many parts of life, and it's not just deaths and morbidity, mortality, DALYs, et cetera, but also the unmeasurables, the degree of social disruption, of destruction of families, and so on. In terms of measurement, it's been my pleasure to be part of an exercise periodically that the World Health Organization does, producing these global status reports on alcohol and health. Pamela Trangenstein is with me, is here today as well. She and I work on this together. And so we're able to say with a reasonable degree of confidence that alcohol is causing at this point about 3.3 million deaths per year. That is 6 deaths a minute. And this is causal. This is not just associated with. Some of these are 100% alcohol-related conditions, things like fetal alcohol spectrum disorders, alcohol use disorders, but also substantial numbers of suicides, of interpersonal violence, traffic crashes and injuries, which we're talking about here today. Most people do think of liver cirrhosis, but far fewer people think of cancers. There are now 7 cancers that are considered to be causally related to alcohol use, including globally 8% of female breast cancer. Here in the US, that figure is 15% of female breast cancer actually considered to be caused by alcohol use. And with the cancers, unlike some of the other things, there is no safe level of consumption. The risk starts to rise in a linear fashion the minute a person starts to drink. So here in the US, then, it's about 88,000 deaths a year. This is the fourth leading actual cause of death in the US. 4,300 deaths a year among people under 21. Globally, it's the seventh leading cause of death and disability, and the leading cause for people from the ages of 15 to 49. It's a component cause in more than 200 disease and injury conditions, and of course, a carcinogen for which there's no safe level of consumption. I should say alcohol itself is a carcinogen. Also, if things go well in your body, alcohol turns into acetaldehyde, which is also a carcinogen. So this is what's happened from 1990 to 2016, which is, and this is from the Institute for Health Metrics and Evaluation at the University of Washington. But alcohol has moved up the chart from number 11 to number 7. And so what is going on here? When you drill a little more deeply into these figures, what you find is that this is happening most noticeably in the low, but particularly the middle-income countries. All over the world, what we find is that alcohol consumption and related problems tend to rise with income. If you're poor and you drink, you will tend to drink more heavily, and the problems will be more visible. But even heavy drinking is actually most common in this country among people who make $75,000 a year or more. Throughout the world, it's most common in the wealthiest countries. So this is an unintended effect, if you will, of national economic and social development. And what's happening is that as other health risks decline with the process of development and incomes rise, the alcohol-related health risks become more salient. However, they're often unrecognized. Alcohol is the great cofactor. People hear about alcohol being good for your heart. What you don't hear is the very significant effect of alcohol on heart disease. Heavy use causes heart disease. And the shift in male mortality at the breakup of the Soviet Union, most of that drop in male mortality was heart disease, and most of it was alcohol-caused heart disease. So in terms of a health for all frame, then recognizing and preventing alcohol-related health problems is key to improving health for all globally. Now, there's something very interesting that's happening here in the US, which is that, shockingly enough, US adult life expectancy has started doing some things no one ever expected it would. For decades, if not generations, this has been on a steady upward climb, and it has been assumed. When I was in graduate school, my demography professor said, yes, this curve is unbounded. We don't know how long people can live yet because it just keeps going up. Well, that used to be the case, but particularly in the first decade of the 21st century, particularly for middle-aged, white, non-Hispanic adults, life expectancy has suddenly dropped. And that is the red line here that you can see. This is mortality, and mortality is increasing. That's the inverse of life expectancy dropping. You can see everywhere else in our partner countries and comparison population Hispanics in the US. Mortality continues to drop, but for white, again, non-Hispanic, middle-aged, and particularly people of lower socioeconomic status, they are dying at younger and younger ages in the context of CVD and cancer mortality continuing to decline. So what the heck is happening? Well, guess what? You've heard a lot about the opioid epidemic, and this is an important factor. Opioids, but also alcohol poisonings are up, and I think the figure is 22% of opioid overdose deaths also involved alcohol. Suicides. The second reason that these are up, and you saw the figure, the estimate in the US, 22% of suicides would not have happened if alcohol had not been in the picture. And then the third that Case and Deaton, when they published this, pointed to was liver cirrhosis. And of course, in the Americas as a whole, more than 50% of that is alcohol attributable. So what's happening in terms of alcohol consumption in the US? It's very interesting. It dipped severely. All the drugs in the US peaked in the early 1980s, and everything started to fall. And they fell until the early 1990s, and then during the Clinton years, everything started to, particularly alcohol, started to rise again, dips down again around the Great Recession, and is now climbing again. In the US, per capita alcohol consumption is rising. And this is confirmed in survey data. We've got two surveys that look retrospectively, and that's only done once a decade. So, but comparing 2001, 2002 to 2012, 2013, for the total population, use in the past month grew by 11%. High-risk drinking grew by 30%. DSM-4 alcohol use disorders increased by almost 50%. And the increases were largest among women, older adults, racial and ethnic minorities, and individuals with lower educational levels and family incomes. So from a variety of different perspectives, we're seeing something. Alcohol was already bad enough, and we're seeing that at least in this pocket of things, it's clearly getting worse. Another recent study looked at emergency department visits from 2006 to 2014, just over that 8-year period. Emergency department visits involving alcohol consumption increased by almost 62% at a total cost of about $15 billion. Again, with the larger change for females versus males. And we're very much in a repeat of what happened around tobacco. Many of you will remember Virginia Slims, and you've come a long way, baby. And colleagues of mine have titled articles about alcohol marketing towards women in the current period, Virginia Slims in a bottle. Because it's very much what's been happening, a very intentional effort to create products oriented to women, to target campaigns at women. In India, Diageo, the world's largest spirits maker, is actually pouring millions of dollars into women's empowerment campaigns across India, which looks like a really, really good thing until you realize millions into women's empowerment. They've paid $3 billion to buy up Indian alcohol production and distribution companies. They're looking to enlarge that market, and of course, they're hoping that Indian women will drink more. So then coming to alcohol-impaired driving, and the reason that the National Academy of Sciences, Engineering, and Medicine was asked by the National Highway Traffic Safety Administration to do the study that I got to be part of, is that along with this climb in per capita consumption, along with the decrease in life expectancy for a particular pocket of the population, we have also stopped making progress in decreasing the deaths from alcohol-impaired driving. We did great for many years, and things like 21, things like 0.08, just very effective at saving lives on the highway. But we're still looking at every day we lose 29 people in the US as a result of an alcohol-impaired driving crash. And on average since 1982, about a third of all traffic fatalities have been from alcohol-impaired driving. In 2016, the number of deaths, 10,497 people. And the second-hand effects of this are significant. This is not just about the driver. This is about the people the drivers crash into. In 2016, almost 40% of the alcohol-impaired driving fatalities were victims other than the drinking driver. This is a huge second-hand effect when you think about second-hand smoking. You've heard so much about that, and that's responsible for only 8.5% of smoking-related deaths. Here we've got 40% coming from a second-hand effect. The economic cost of these crashes, about $121.5 billion a year. In the international context, we are way ahead of our countries that we could easily be compared to in terms of wealth development, et cetera, in an arena that we definitely don't want to be way ahead. Now, these figures have not been adjusted for vehicle miles traveled. That would bring us down somewhat, but still, this is an area where the US did not need to be a leader. I also wanted to put the per se limit on drink driving into a global context. And this is data that Pamela and I put together from a survey that we worked with WHO on. These are 2015 data and what the world looked like in terms of what was the acceptable level of alcohol consumption when you get behind the wheel of the car. And you can see this is truly the greening of the world. In that most of the world is at 0.05 or lower, and then we have the pink countries, and that's places like the US that are substantially higher than 0.05, currently at 0.08. The current status of the problem in the US, young drivers are disproportionately involved in the fatal crashes compared to other age groups. In 2015, the 21 to 25-year-olds accounted for 28% of the crashes where the driver had a blood alcohol concentration equal to or higher than 0.08%, just completely disproportionate. And another key area is rural areas, also disproportionately affected. Just a little more context and I'll be done. A lot of impairment is about people's ability to assess whether they're impaired. And I laugh at the alcohol industry slogans like know when to say when. Because of course, the more you drink, the less good your judgment is about knowing when to say when. And many factors affect people's ability to drive, to do other high attention needing activities, weight, age, sex, race, ability to metabolize alcohol, and so on. Serving sizes, what a mess. True stories, I have a master's in mixology. I worked my way through college as a bartender. And I definitely know the difference between the pour when you like the person and the when it's just the average schmuck off the street. Also, the increasing practice of combining alcohol with caffeine and other energy drinks, the research on this creates a population of wide-awake drunks. They are just as impaired in terms of motor skills, but they're awake. But the other issue is that alcoholic beverages are constantly changing. They are far more affordable now. The most recent tax cut package in the US gave the alcohol industry a 16% drop in alcohol taxes. Got very little coverage. Early estimates is that alone will be attributable for about 1,500 excess deaths, including between 280 and 630 deaths on the highways. Just that one act of making it more affordable. They're of fire greater variety and they're more widely promoted. So just a little bit about that variety. This is the Four Locos of the world. We call these supersized Alcopops or a binge in a can. This is 23.5 ounces of 12% alcohol sold as a single serving. That's the equivalent of about 4.5 beers sold as a single serving. And you can see the price comparison there. That is being sold at 11 cents an ounce. It is very difficult to get any other liquid, water, juice, soda pop, etc., at that inexpensive a price. And then the next generation of these, the alcoholic sodas, not your dad's root beer. The thing that horrifies a lot of us, powdered alcohol, and will be in the Maryland legislature later this week and next week, testifying to get a permanent ban on this to make Maryland the 36th state to permanently ban the sale of powdered alcohol. I love this cartoon, the death puppet saying, just add teenagers. But the next wave that people are not talking about nearly enough are the craft beers. And craft beers are generally higher strength than regular beer. So I've picked Black Tuesday here. Black Tuesday is a particularly strong one. It's actually 20% alcohol. So that in 12 ounces, the equivalent of 3.8 cans of regular beer. And, anecdotally, we're hearing from first responders, they pull somebody over and the driver says, oh, well, I only had a couple of beers. They were craft beers and they were substantially stronger than you're used to. You are impaired. So then just a little on the conflict of interest issue. It has been up and around for years. And the industry is on record as saying they encourage responsible decision-making, no drinking by underage drinkers. They strongly abuse inappropriate consumption of their products, but they will never define what inappropriate consumption is. They will never define abuse. In the US, we define binge consumption as 4 or more for women in 2 hours, 5 or more for men. This gets the average drinker to 0.08 within 2 hours. The photo is from the Four Loko website. And more than half the consumption in the US is in the form of binge drinking. At least 2/3 of US consumption is in the form of binge drinking. An earlier study that looked at this found that if underage and pathological drinking were eliminated, the industry would lose at that time about $48 billion in sales, or about 37.5% of their sales. It's closer to 50% of their volume. So the conflict is here. If everyone drank in a safe and responsible manner, the alcohol companies would face a market half the size of what we have today. They'd lose at least 1/3 of their products, and no publicly traded company can intentionally lose this much of their market and survive. And therefore, the alcohol industry has a basic conflict of interest with safe and responsible drinking. Now, take the development of the last 2 days, where the UN Institute for Training and Research, UNITAR, an arm of the United Nations, has signed an agreement with Anheuser-Busch InBev under the real SDGs. I should say Anheuser-Busch InBev has their own version of the SDGs. They're called the Smart Drinking Goals. We don't think it's a coincidence that that also stands for SDG. And what will they be doing under this agreement? They'll be helping design road safety codes, promoting education and creating technology applications that enhance mobility and reduce traffic crashes. They'll be promoting conferences and training workshops and targeted interventions in countries with the highest death rates due to traffic. Now, what word is missing from this slide? Alcohol. There's not a single mention of the word alcohol, because clearly alcohol is not a problem in driving. We actually, with Adnan and with Marissa Esser, a graduate of the school, we looked at 266 global initiatives that the alcohol companies had promoted as actions to reduce drunk driving. Actually, 0.8%, or exactly 2 of those interventions out of 266, were consistent with global public health evidence of effectiveness in reducing drink driving. So now we'll hear from Amy about what the scientific community thinks is effective. Thank you very much.
Great. Thank you very much, David, for that a remarkable review in such a short time. The science of alcohol and its impact on public health clearly is immense, and you've narrowed it down. I must say that the fact that we have both an evidence problem, that is the lack of recognition of evidence, as well as a political problem now with the UN agencies signing on board, does present tremendous challenges. And I hope that maybe in the discussion we can raise some of these questions and get your responses to that. So I think it's a nice segue into actually focusing in on the evidence. And in this case, we will limit the discussion for the next 15 minutes or so around driving and drinking. And that's because this is one of the tremendous areas in which we see an immediate impact of both alcohol consumption as well as alcohol control. So I'm delighted that Amy Geller, who's a senior program officer at the National Academies of Sciences, Engineering, and Medicine, and her staff have come today. Thank you very much for making the trip from DC, and looking forward to hearing from you.
Hi, thank you for this opportunity. So as Dr. Hyder mentioned, this report came out in January. And I'm going to give you an overview of the committee process very quickly and then dive right into the recommendations. So this was the study committee. They are the authoring committee. You can't necessarily tell from their affiliations, but they're a multidisciplinary group covering a large range of expertise. And as you can see, Dr. Jernigan was a member of this committee. So this was a statement of task given to the committee. In essence, they were asked to look at the evidence and do an evidence-based review on which interventions will work to end or to accelerate progress on reducing alcohol-impaired driving fatalities. And then barriers to action, and then which interventions that currently exist need to be changed or adopted. We also looked internationally for examples and evidence as well. So they held 5 meetings. We had information gathering meetings that were open to the public. They authored a report that then went through a rigorous external report review process. The committee took a holistic public and population health-based approach. They did a comprehensive literature review, but we aim to build on many of the very well done reviews that have already been done out there and that already exist. And then the committee, in their report, they embraced the Vision Zero philosophy, which essentially says no traffic fatalities are acceptable, that we can't rely on individual behavior alone, that we need to make the supporting systems and structures more amenable to reducing and eliminating deaths. We had 4 papers that informed their work. One on global lessons that was very informative that Dr. Hyder and colleagues authored. So this is the committee's conceptual model. And it builds off of the Haddon matrix. And so this is just to give you a sense of what the committee looked at in terms of intervention. So they looked at everything from alcohol consumption all the way through to fatalities. So that includes alcohol consumption, drinking to impairment or excessive alcohol consumption, driving impaired, and then the potential for a motor vehicle crash or arrest, and then serious injuries or death. And of course, you can come off of this at any time. You might drink to impairment but then not drive, or you may drive impaired and not get in an accident or arrest. And then there's a number of intervention areas at the top, and of course all of this happens within the social, economic, political, legal, and physical landscape. So the report has 8 chapters and 16 recommendations, and then a number of other findings and conclusions. I'm going to focus on the recommendations for the most part today. So chapters 1 and 2, David basically already gave you a great background on. It gives you the extent of the problem. That alcohol-impaired driving remains the largest cause of death on our roadways today, and it's a complex problem, but it's preventable with a comprehensive and multi-sector approach. And then chapters 3 through 5 look at system-wide interventions. And then we have a chapter that looks at data systems and how those can be used to inform this problem. And then we have a chapter that talks about social movements, community-based coalitions, and media approaches, and engaging other stakeholders in what they can do to help prevent this problem. So as David mentioned, I believe binge drinking is a big problem here in this country, and it's strongly associated with alcohol-impaired driving. Binge drinking accounts for 85% of alcohol-impaired driving episodes. So the committee concluded that policies to reduce binge drinking are also protective against alcohol-impaired driving, and that the adoption of a comprehensive set of interventions and population-based strategies that take advantage of synergies across interventions would further accelerate progress and reduce binge drinking and related harms. And this is just, the conclusion that this is a significant public health problem. It's persistent and requires a multi-sector approach. So now I'm going to talk about the committee's recommendations. I'm going to maybe highlight a few of the findings and conclusions. Before I do that, I wanted to bring up the one question that's always coming up. What about autonomous vehicles? That'll solve the problem, right? And yes, eventually, hopefully it will solve the problem. But right now, as David mentioned, we have over 10,000 deaths a year. And the last 2 years, that number has gone up. And by some estimates, it could take 40 years to get fleet penetration here in the United States of autonomous vehicles, and that's way too many lives to lose in between. And then, in addition, a lot of these, not all, but many of these recommendations have other protective factors for other alcohol-related harms. So, for example, alcohol-related violence and other things would be impacted as well by these recommendations. Autonomous vehicles are promising and important, but they're not the answer today or even in the next few years. And also, I just want to note that in some cases, the committee did need to balance personal liberties along with population health, and where they did make recommendations that some might view impinge on civil liberties, it was decided that based on the evidence, the great positive impact they would have outweigh the potential to impinge on personal liberties. Sorry. So the first recommendation I'm going to talk about are increasing alcohol taxes. So alcohol taxes have strong and consistent evidence that they reduce binge drinking, and there's strong direct evidence that shows higher alcohol taxes reduce impaired driving and motor vehicle crashes. Alcohol taxes have declined in inflation-adjusted terms in both the federal and state levels. This graph on the side here shows that average inflation-adjusted specific alcohol excise taxes among U.S. states from 1991 to 2005. The alcohol taxes are considerably less than the alcohol-induced costs. They're a small fraction of price, and they don't cover alcohol-related harms. For example, the external cost of one standard drink is approximately $2. About 40% of that is paid by the federal government. And then by comparison, after factoring in federal and state alcohol taxes, the average tax per standard drink is around 11 cents. So the harms are $2 and the taxes are about 11 cents. Okay. So, therefore, based on this strong body of evidence, the committee recommended that federal and state governments should increase alcohol taxes significantly. By significantly, they meant that it should have a meaningful impact on price and therefore reducing alcohol-related crash fatalities. They should comprise a meaningful percent of net of tax price, so about 30% or more of alcohol products, and cover the marginal or external or secondhand costs incurred by the sale of alcohol. So, and I should say these recommendations are organized by that conceptual model I showed you. So right now we're sort of talking about the drinking phase. In addition, the evidence shows that addressing physical availability of alcohol has strong evidence for reducing excessive drinking and related harms. So the committee recommended that state and local governments should take appropriate steps to reduce alcohol availability. So this includes restrictions of the number of on and off premises alcohol outlets and the days and hours of sales. Further, the committee recommended that to stop illegal sales, so that's to those of individuals under 21 years of age or already intoxicated adults, that the federal, state, and local government should adopt and strengthen laws and dedicate enforcement resources. In some places, the laws are on the books, but they're not regularly enforced, and therefore don't do anything. In some places, some states, that there is the need for adoption or strengthening of those laws. So, the committee also noted in its research that young people are at higher risk for alcohol-impaired driving and are influenced by alcohol marketing. Numerous studies show alcohol industry self-regulation of marketing is neither effective or sufficient. Right now it's voluntary. And the standards are vague and permissive, and they're definitely not consistently followed, and there are no penalties for not following these voluntary standards. So therefore, the committee recommended that government at all levels should use their existing regulatory powers to strengthen and implement standards for permissible alcohol marketing content and placement across all media, establish consequences for violations, and promote and fund counter-marketing campaigns. And then the committee also recommended that as part of a comprehensive approach, that well-funded media campaigns are an important component of reducing alcohol-impaired driving, and they're, of course, more likely to be effective with well-done formative research, and so you shouldn't just say, this sounds like a great idea, this is a good catchphrase. Really need to be informed by the literature that's already out there, and in addition to doing other research. Okay, so now we're going to switch to alcohol-impaired driving interventions. So this part you've already perhaps drank to excess. And so I'm going to talk about the blood alcohol content laws right now. So currently in all states, blood alcohol content laws are decided at the state level, and all states have a 0.08 BAC. Except for Utah, they passed legislation that will go into effect in December to have a BAC of 0.05. but that's not yet been implemented, and it's to be seen how it gets implemented, and they are the only state as of now to have done that. Although shortly after this report came out, an assemblyman from New York decided to reintroduce legislation to reduce the New York State BAC to 0.05. So evidence consistently shows that the ability to operate a vehicle deteriorates significantly at 0.05 and even earlier than that. In many developed countries, the lower BAC laws have decreased alcohol-impaired driving fatalities. And importantly, lower BAC laws are associated with decreased crashes at all levels of BAC. So we're not only talking about the people who are currently driving at 0.05 to 0.79. We're talking about the overall deterrent effect. So the committee recommended that state governments should enact per se laws for alcohol-impaired driving at 0.05 BAC, and that the federal government should incentivize this change, as was done when the BAC was reduced from 1.0 to 0.08. And that the enactment of 0.05 per se law should be accompanied by media campaigns and robust, visible enforcement. The effectiveness of this policy will be heavily dependent on enabled by other interventions, such as the use of sobriety checkpoints, administrative license revocation, and penalties for refusing a preliminary breath test that are equal to or greater than what the penalty would have been for the alcohol-impaired driving offense. Okay. So, speaking of sobriety checkpoints, the evidence is very strong that they are effective, and the committee recommended that states and localities should conduct frequent sobriety checkpoints in conjunction with widespread publicity. There are some states that do not allow sobriety checkpoints. They're not allowed by law. Some are allowed by law, but there's no funding allocated towards them. High visibility enforcement is a really effective strategy. There are also low staff checkpoints that can be done that cost a lot less money, and our evidence shows are also very effective. And the ideal frequency of these checkpoints, there's not a lot of strong evidence on that, and so that's something that needs to be researched. So some of you may have heard of the Driver Alcohol Detection System for Safety. So this is DADS, and this is a technology that is in development as a non-invasive way to test the driver's BAC. So it could be by their breath, by just being in the car, or by touch when they go to start the car. There's a partnership between NHTSA and the Automotive Coalition for Traffic Safety to develop this, and it's been underway. It's not ready yet. It's not clear when it will be ready, but because of the potential population health impact, the committee found this a very promising way forward. And so they recommended that once it is accurate and available for public use, auto insurers should provide policy discounts to stimulate the adoption of DADS. And that also, once the cost is on par with other existing safety features like airbags and things like that, and again, demonstrated to be accurate, NHTSA should make DADS mandatory in all new vehicles. Okay. So the committee recommended that municipalities should support policies and programs that increase the availability and convenience of safe transportation alternatives, including permitting transportation network company ride sharing, such as Lyft or Uber, something like that, where some jurisdictions actually do not allow them to operate, enhance public transportation options, and boosting or incentivizing transportation alternatives in rural areas, because that's an area where it's definitely not widely available. And currently, I'm sure, a lot of people also think similar to autonomous vehicles, that Lyft and Uber and, smartphone-enabled systems would be like the solution to the problem. But the evidence on the few studies that have been done is mixed. Some show an effect, some don't. However, the negative effects aren't there either. And so the committee saw that as, again, it's promising. And so at a minimum, they should be allowed to operate. But it's definitely on the promising in terms of evidence right now. So I pulled this one out just because this is about designated driver programs. So the committee found that there's insufficient evidence to determine if they're effective. And the reason this is important is because there's a lot of stakeholders who use this as a key thing that they focus on and that they fund. And it really, depending on how it's done, may have no impact. And so it shouldn't be solely relied on. And so I pulled it out just because, it is something that we've all come to accept. Public opinion seems to be positive, but it's unclear how effective those are. Okay. So now we're going to get to post-crash and arrest. And these I'm just going to go over very quickly at a high level, but I'm happy to give you more information. So DWI courts, which are post-conviction courts that combine comprehensive monitoring with substance abuse treatment. The committee recommended that these should be available in all states and should stick to the guidelines by the National Center for DWI courts. They've been shown to help reduce recidivism, and that all healthcare systems and payers should cover and facilitate evaluation, prevention, and treatment for binge drinking and alcohol use disorders. So this would include SBIRT, cognitive behavioral therapy, and medication-assisted therapy has been shown to be effective for sure for certain groups who suffer from alcohol use disorder. So ignition interlock. So I think you all know you blow into a device that's attached to your car, and if your BAC is too high, usually 0.02, it won't start. These are a very underutilized resource. They're currently allowed for all offenders in 30 states, DC, and 4 California counties, but although use has increased, they remain underutilized relative to the number of people who would qualify to get them. And so the committee recommended that all states should enact all offender ignition interlock laws to reduce alcohol-impaired driving fatalities. They're very effective, and that it should be required for all offenders who have a BAC above the limit set by state law. And to increase their effectiveness, states should consider increasing the monitoring periods. They range tremendously by states from 6 months to several years. Sometimes it depends how many times you've offended. Based on the research, it looks like a minimum of 2 years for a first offense and 4 years for a second offense would be effective. So I'm not going to get too much into data and surveillance needs because you're going to hear a talk on that next. But the committee did devote an entire chapter to this, and recommended to NHTSA that they ensure timely and standardized data collection, and that data collection is looked at across agencies and should explore the usefulness of big data. And then to facilitate surveillance of alcohol-impaired driving that's ongoing, concise, and actionable, they should convene a group of diverse stakeholders that includes a number of stakeholders to create and maintain a metrics dashboard, no pun intended there, publish brief and visually appealing quarterly, annual, national, state reports. So, make sure the public knows about these, make sure the data is conveyed in a way that gets to them and gets to policymakers, and is actually, useful. There are certain types of data that aren't collected at all at the government level, such as place of last drink, which would be a very informative piece of information to know. And then finally, the committee talked about generating action. And so there are things that the alcohol producers and alcohol industry can do to assist efforts to reduce fatalities. One would be potentially reducing the alcohol content of existing products, refraining from marketing, including sponsorships that are likely to influence excessive alcohol use, such as NASCAR, related directly to the driving, and supporting or at least not opposing effective alcohol-impaired driving countermeasures. Often the countermeasures that they use aren't necessarily those that are most evidence-based, and so they should focus on those that are, for example, in this report, and that are supported by the evidence. And then that the committee recommended that the National Conference of State Legislators, NCSL, should draft model legislation to help provide state benchmarks to states. What each state needs is going to be different depending on what's going on there, but at least that could provide benchmarks for them to move forward. They made a recommendation for a interagency coordinating committee to help with an integrated approach, and then that NHTSA under other federal federal partners and private funding sources should be free of conflicts of interest, should support training, technical assistance, and demonstration products and the implementation of effective strategies. So, for example, as David always likes to point out, MAD, the way they came about was actually funding, a small amount of funding from NHTSA, and in this sort of demonstration project kind of way, and they ended up having a huge impact. And so by having more of these, a little bit of money can go a long way. And so especially if there's assistance and technical assistance for them in training. So that could be a very important way to help us get movement again. And so finally, the committee concluded the report that to achieve the goal of zero alcohol-related crash fatalities, a systematic, multi-pronged approach is needed with all sectors. And so in the report, both in the summary and Chapter 8, we have listed out in a table longer than this, all the different potential evidence-based, from promising through evidence-based interventions that the committee recommends in the report, who the stakeholders are that have a role in implementing those, and whether the time frame, if these are things that can be done in 0 to 2 years or a little bit longer or long term. And I'm going to end there, and I'm happy to answer any questions. The report is available for free as a PDF download at nap.edu. Thank you.
Thank you very much, Amy, to you and the National Academies for, first of all, doing this report and the committee in which David and his colleagues obviously led the way. I think that the fact that Utah is leading the country should be congratulating Utah, already having a limit of 0.05, but I think getting there and very well thought out recommendations. And I think that this has implications not just for the US, but also for low and middle income countries, and maybe we can talk about that in a bit. So this would be a great segue now to talking a little bit about data, and I'm going to invite our PhD candidate, Nukhba Zia, to talk a little bit about lessons from alcohol data systems and summarize the type of information systems that can help inform the policies as well as some of the actions that we need to take. So Nukhba, over to you.
Thank you, Dr. Heather. So I'm going to talk about lessons from alcohol data systems. And as we talk about that, I want you to think about 3 questions, and we're going to walk through those 3 questions over the next 10 minutes or so. So the first question that we want to think about is, what are the current recommendations on drink driving data systems that are available to us? The second question is, what is the current data system in the US? And I'm sure most of us are familiar with the data system, but just to walk through. And then what are the gaps and how we address those gaps as we look through these data systems? Because we are public health practitioners, data is everything to us. Nobody's going to listen to us if we don't have good data. So in terms of current recommendations related to road traffic injuries and also alcohol-related data, there are 2 resources that I would like to point here, and these are the resources that are put forward by the WHO. One of them is a resource specifically on drinking and driving, and the other one is on data systems. So putting these 2 data systems together, these 2 resources together, the suggested set of variables for any drink driving data system can be categorized into these 5 broad categories. Person characteristics like age, gender, ethnicity, race. Crash characteristics, which can include location of the crash, date and time of the crash, type of crash. Road characteristics, which includes the type of roads the crash had taken on. And then vehicle characteristics, the type of vehicle, whether it had safety gadgets in there or not, and the cost associated with these crashes. And the variables that are specific for drink driving include suspected use of alcohol, which is generally recommended is done by police, and it's a binary variable, so yes or no. The status of alcohol test, which means whether the test was given, if it was given, was there any refusal, or was the test not given at all, or if there's no known status on that. The type of testing that is conducted, so whether it was a blood testing or whether it was a breathalyzer that was used for testing, and the test results. So why we need all these standardized data systems and data variables is because we want to engage with the host of stakeholders that Amy just mentioned. And these stakeholders are not only applicable within US, but are also applicable for other countries that we work in, whether it's high-income countries or low-middle-income countries, everywhere. So having a common language helps with that. And based on these variables, we also devise standard indicators, which are very helpful when we are reporting these data and in our dissemination activities, because we're not just collecting data, we want this data to be effective for policymakers to use and to make the interventions. And then it also helps in evaluation and assessments of interventions that we eventually want in order to address the issue. So what we have currently in the US is FARS, which is Fatality Analysis Reporting System. This was established in 1975 by National Highway Traffic Safety Administration, and it collects data from all the 50 states, District of Columbia, and Puerto Rico. It has over 150 variables, so it's a wealth of data that's in this data source, and it collects data on all the recommended broad categories that we just talked about from various resources. So police, hospital, emergency departments, coroner's office reports. So all of those resources are feeding into this data system. And alcohol-specific variables are the ones that are suggested. So police reported alcohol involvement, the method that was used for alcohol level determination, the status of the alcohol test, type of test that was given, and the test results. And the reports for these are available for national level numbers and also for states. Now, moving forward, we did this exercise where we wanted to understand that how we can use these data systems, data system within the US, and identify the gaps that are there and how we can address that. And in doing that, we basically developed these assessment questions. These are not standardized questions, but these are the things that we need to think about whenever we are making any comparisons between data systems. So we want to think about what type of data system is available in a country to collect data on drink driving. Is it just national level data that's available, or do we have provincial or state level data available to us as well? What agencies and organizations are collecting this data? Is this data being collected by the government or any ministry based within the government, or is it an NGO that's collecting the data? And then who collects the data? Because that's the important part where the data quality comes in. And then what's the frequency of data dissemination? Stakeholder engagement is very crucial, and we need good data for that. And if available, how these databases are linked with other databases. So for example, non-fatal databases or insurance-based databases. So just thinking about these questions help you, streamline your thought process whenever you're looking through different data systems, not only within US and other high-income countries, but also low and middle-income countries. So over the next 4 or 5 slides, I am going to walk you through some variables that are recommended by the WHO from the 2 resources that we just talked about. And I'm going to be making comparison of FARS, which is the US database, with some selected high-income countries that have similar profile as the US in terms of socioeconomic strata and in terms of drink driving being an issue in those countries. So the 5 countries we'll be making comparisons with are databases from Australia, New Zealand, Sweden, France, and Switzerland. And there are 2 things that we would really want you to focus on. The first is that we have that set of variables in the first column, which basically are the variables that are suggested by the resources that I pointed out. And then, looking at across the different countries, we see that FARS is doing pretty much a good job when it comes to drink driving specific variables. So we have that data available to us, except for this one, the effectiveness of drink driving law is something that's missing from the current FARS system. In this second table, we have variables related to person characteristics. Again, FARS is doing a pretty good job. The next nearest one is Sweden, but then the rest of the countries are not getting into the depths of person-related characteristics. The variables we are missing in FARS are passenger position, where they were in the vehicle, front seat passenger, back seat passenger, and then the type of injury they sustained. So was it head, arms, where the injury had taken place. This table is showing multiple variables. So we have road characteristics, we have vehicle characteristics, and then road behaviors, which include speeding and use of restraint. Again, FARS is doing pretty good, and Sweden is the second country. Just keep in mind that we are not presenting all the countries and their data sets. This is just based on some brainstorming that we ended up doing and developing these tables. Now, this table is really interesting because it has a lot of yellow for FARS, but that's because we have, most of these data are related to non-fatal road traffic crashes. So that is something that's not in FARS because it was not meant for that, but that is something we need to look into as we go forward. So those were the variables. Now, based on these variables, the recommended indicators that we should be considering are three main indicators. The first one is percentage of road traffic deaths involving alcohol, and this is stratified by drivers and the riders. The second one is number of alcohol offenses detected. And the third one is percentage of drivers who were stopped and had a blood alcohol level above the legal limit. And again, we see that FARS is doing a pretty good job because that's the only database that's been able to give us stratified data based on drivers and riders in terms of percentage of deaths that are being caused because of drink driving. So based on this overview, which is very brief, some key messages that we want you to keep in mind as you go through different data systems for drink driving is that the high-income countries have national and subnational data systems, but as you saw through these tables, both for variables and indicators, that there's great variation in how these data systems are being used and what type of variables are present in them. So having a standardized data system across these countries is also important for comparison purpose. And this lack of standardized data has implication not only for us domestically, where we want to evaluate interventions, but it also has implications for global control related to alcohol and drink driving, because it's not just an issue of high-income countries. The low-income countries where most of us work, is like drink driving is a problem over there as well. So that's for high-income countries, that we need to standardize our data systems. But for low and middle-income countries, it's important that they don't blindly follow example of a high-income country. They need to look through the recommendations. Formative work is also important, and engagement with stakeholders to put together a data system that's able to serve the purpose that a data system should be serving. And then also the importance of including morbidity or disability-related data and cost data, because the true picture is with mortality, morbidity, and the cost associated with these data. And that's it, and thank you.
Thank you very much, Nukba, for that quick review of alcohol data systems. Let me invite my three colleagues to sit on the panel here, and we'll have a few minutes before we serve lunch. And I think it's just to get a few highlights of the questions. We don't have too much time, but I'd like to spend maybe 10 minutes, and then we can mingle more over lunch. So if you have a question, a concern, an opportunity to ask for a clarification, please put your hand up, and I'm hoping that Eric and maybe somebody can help Eric get a microphone to you. Please do speak in the mic as well. So yes.
Yes. Oh, hi. How are you? Thank you so much for the presentation. So very quite informative. So I'm from Malawi. I'm a physician from Malawi. And the common syndrome that we had was, I'll call it the post-Friday night syndrome, whereby if you go around in town on Saturday morning, you find about 3 roundabouts where there's been a car crash. And I find the issue of prevention of drunk driving, it's quite tricky. Okay, so because most people, there are all these adverts, they say, okay, driving is not safe, but everybody knows that. So my take is that maybe we could look at more passive methods of how you can prevent somebody from drunk driving. I know you mentioned a few of, like, if you drunk drive, you blow into a breathalyzer, and then the car doesn't start, something like that, more passive injury prevention methods. But I always ask, in terms of the other target population that would have would be is there any studies that you have done concerning pub owners? Like, they're the last people who see the person as drunk. And what kind of methods or could
Thank you.
Yeah.
That's a great, I'll take 2 or 3 and then I'll ask the panel to respond. Yes, right next to you, yeah.
Hi, my name is Warugoro. I can start with a disclaimer that I'm a biker, so I drive a motorbike. And my question has been in terms of alcohol and motorbikes. From what I understand, the limit, at least here, is the same, so 0.08. But my experience is I think it should be lower or none. So is there any research or anything that talks about motorbikes and riding and alcohol,
Great.
and what those limits should be?
Great, so excellent. And I'll take one more right up front here, the gentleman. Eric, right here. And then we'll do a second round.
Thank you. So you mentioned about the autonomous driving vehicle, and I know it will take a long time to be on the ground, but there are already existing technology for some car manufacturers that have a very robust safety systems. So as these things grow further and further, how do you think alcohol prevalence will change? Will people encouraged to drink more because they will be more confident in the car? And if this will happen, does this mean that we will have higher prevalence of cancer, liver cirrhosis, and other diseases?
Sure.
So how this will play a role in public health?
Great. Thank you very much for those 3 questions. Let's start with David and move in this direction. You can pick and choose which question or any comments you want to make.
Okay, thank you. Yes, first, responding to my colleague from Malawi, yes, there's a tremendous amount that pub owners can and should do, but a lot of this will come through regulation, and it is things like changing the hours of sale and the days of sale. A lot of this in a country like Malawi can involve actually needing to bring the providers of alcohol into the formal market because they're often informal. And so the first step is often licensure, but then with licensure can come the possibility for controlling. The hours and days of sale is amazing. Any change 2 hours in one direction or the other will have predictable public health effects. The big story there is Brazil, a modest-sized city of about 400,000 people, changed from 24-hour opening to 11 p.m. closing and cut the murder rate in half in the next year. It's really amazing. In terms of alcohol and motorcycles, there is absolutely justification, I think, to be going for a lower BAC there. It's been so challenging just to get helmet laws.
Yeah.
Motorcycles seem to be associated with personal freedom. And yet I was involved in the motorcycle helmet battles in California years ago, and that personal freedom needs to be weighed against the cost that all of us are paying, both personal and financial, in terms of the toll of motorcycle crashes on the highways. And I'll let you take the autonomous vehicles question? No, you want me to take it?
Well, it's more about what the public health impact will be once people don't have to worry about driving anymore, they can drink more, right?
Yeah. Surely it's conjectural, but it's important to realize that here in the U.S., alcohol-related motor vehicle crashes are only 19% of the deaths already. So the other 81% will definitely still be there unless we're doing other things. And the beauty of the committee report, I think, is that so many of the other things will affect those alcohol-related deaths across the board, not just the alcohol-related motor vehicle crashes.
Yeah. Amy
Yeah.
or Nukba, any comment?
Yeah, so on that last point, I agree. If while we don't have all these other safety features in place or autonomous vehicles, if things like higher alcohol taxes and, that's why the committee took a comprehensive review looking at from, before you even drink to being in a crash or arrest, is because if you look at it more holistically, then you're addressing a lot of the underlying problems of drinking. And so things like the recommendation on treatment and that being covered, that would have long-lasting impacts. If not saying that once fatalities go away, these things should go away, they need to stay. So we need to continue having higher alcohol taxes. We need to continue having, SBIRT and things done at times when folks go to like the emergency room, taking advantage of the times that we have to assess them, because binge drinking, while they might not have an alcohol use disorder now, they might be perhaps on the verge of having one. And then, go ahead.
Well, the other issue is going to be drunk pedestrians.
Yeah.
And this is a huge issue already in places like Cape Town, where there are arguably more pedestrians than there are drivers on some of the roads. And I've seen the data at 5 o'clock in the afternoon. The deaths of drunk pedestrians are just horrifying.
So the cars will not hit any pedestrian. And another complex issue is death from cars, whether pedestrian or the drivers, are one of the main source for organ donors. So organ donors will go down. But if people will consume more alcohol because they're more confident in the car, then there will be more need for organs, especially the liver.
Yeah.
So how this will be balanced.
Yeah, I mean, I think if I could just, the David Ward, who heads the Global New Car Assessment Program, says that there is no chance in the next 25 to 30 years that any autonomous vehicle fleet will comprise a sizable proportion of any fleet, particularly when 90% of the world's fatality exists. So it is conjectural. I think it's very important, actually, for us to answer some of these questions you're raising, because it is about trade-offs in public health. And what the positive impact will be, what the potential negative impact or negative externality might be, is something very significant. But like David said, it is conjectural. I am, for at least the next 25, 30 years, less excited about autonomous vehicles myself, because I think we have so many other issues to tackle, particularly where these issues are happening. I did want to add that in some countries, by the way, the limit for motorcyclists is actually higher than for vehicles. So in Vietnam, they accept 0 actually BAC for cars, but 0.05 for motorcyclists, even though that's a substantial proportion of their vehicle fleet. So I think there's a lot of room for learning in these areas. Nukhba, did you have a comment? Otherwise, I'll take a second round of questions.
Just like saying that data, again, is very important to engage with stakeholders. So if there is substantial data that shows that the type of vehicles that are involved and the riders on the vehicle, that can make a case for developing policies around the legal limit that should be set based on vehicles. So like the example that we have is from the road safety project we do, where speed limit is different for different vehicles. So it's doable, but you need good data to show what needs to be done.
So we have 5 minutes left, which I want to close up, but if there's a question or two which people have, I'll take one here and one at the gentleman at the back. Yes.
Thank you. I got lucky. Thank you for the presentation. And you mentioned several structural interventions to address the consequences of drink driving. Have you looked into the structural factors that determine the drinking patterns? And is there a room to do something there? Why people start drinking more, and as a result, the life expectancy decrease.
Sure, great. And we'll take one more back there.
Great talk, thank you. The question is, you pointed out a lot of bad things with alcohol, like cirrhosis, breast cancer, pancreatitis. A lot of people talk about having 1 unit of alcohol is good for you. They have a longer longevity, and the French paradox, where they eat as much meat as their European counterparts, but they live longer because allegedly red wine and tannins and all that. What have you to say about that? It's even entered scientific journals.
Okay, great. So any other burning question, if somebody will be really upset that they didn't get to put in a question? Otherwise, let's take those two. This time, let's start from Nukhba down to David, and then we'll leave the rest of the conversation for lunchtime.
Well, I mean, I think in terms of the structural factors...
in the microphone, Nukhba, please. And you can make a final comment, each one of you, please.
Yeah. So I think, again, since like most of my work has been around data systems and, understanding the data, so getting an input on the structural modifications, and I don't know if you had like any specific structural modifications in mind, but like, like we have interlock systems for the cars. So, you have things that can be done with the vehicles to kind of like help and address the issue. But obviously, those are things that need to be catered to where you are and how you're going to use the interventions to address the issue.
Great, thank you, Nukhba. Amy?
I don't have much to add. I mean, the report, if you read Chapter 2, did get into background and patterns of drinking and who's drinking. And so that's one of the reasons that the committee focused on binge drinking, because that was shown of the group that has the largest number of fatalities. There's a high number of them who do binge drinking. And so a lot of these policies focus specifically on those who binge drink, so it should impact them. But they didn't look at, necessarily what the patterns are for why people are drinking more or things like that. But again, data would be very important. And I'll leave it to David to focus on the fact that one drink is...
Thank you, Amy. David?
Okay, structural factors, absolutely. The committee looked at those, and they are things like taxes and like physical availability, like marketing, particularly for young people. The evidence is just continues to pile on that the more kids are exposed to the advertising, the more likely they are, in particular, to move from experimentation to binge or hazardous drinking. And also things like beverage strength, labeling. The amount of consumer information on these things is pathetic. and then service practices, which is sometimes a lower hanging fruit than some of the others. Alcohol in the heart. So glad you asked. What I often say is alcohol might be good for your heart if it were the only organ in your body. And in fact, the best epidemiologists in my field disagree heartily at this point about that whole body of evidence. The biggest issue is the failure of the longitudinal studies, of the cohort studies, to remove sick quitters from the abstainer or reference category. And when you actually take those out, suddenly the effect seems to disappear. So there are, I would say generally, there are many reasons that people would decide to drink. I wouldn't say that your health should be one of them.
Thank you very much. That's a apropos statement. And I agree, the latest systematic reviews from cardiovascular health are indicating that the 2 drink a day, particularly red wine a day, etc., estimations were actually overestimated. And in fact, even in the global burden of disease methodology, that has been adjusted for. So first of all, I think this has been really, really informational, certainly for me, in beginning to think about the impacts of alcohol in public health, particularly in the area of drink driving, and David's perspectives around how to address this, both from a marketing perspective, from the perspective of policies and conflicts of interest. And then Amy and the National Academy of Sciences, Engineering and Medicine, your report, which is going to be incredibly powerful, I hope, in influencing policies not only in this country, but let's try and figure out how we can use some of that evidence and take it to where 90% of the death and disability occur from things like drink driving. And thank you very much for your review of alcohol data systems, and we hope that we will continue to try and collect this type of information. On behalf of the Johns Hopkins International Injury Research Unit and Department of International Health, I want to thank all of you for coming today, for presenting, and for all of you for participating. Thanks to all of you who are watching us live. I've been getting a lot of Twitter messages and also other types of messages. Thank you for joining us. Please remember that this recording will be archived, so if you have friends and colleagues who you think should have watched this, let them know, and it will be available on the website. Thank you very much, and please join us for a light lunch in the neighboring room. Thank you.
Thanks for having me.